Hi everyone, it's Dr. Sloan and we're going to talk about respiratory medications. Please note that anything that is a prototype, which is something that you need to learn, will have this PR in front of it. All right, let's get started. Okay, we're going to start with glucocorticoids. And if you've been paying attention, you know that the other word for glucocorticoids is steroids. And we're going to talk about inhaled versus oral corticosteroids. Probably the thing that's used the most for day-to-day management of respiratory issues like asthma and COPD is inhaled corticosteroids. And we'll talk a little bit about that, but there's less side effects with inhaled corticosteroids because you're not taking them and ingesting them and putting them into your system. You know, if we swallow prednisone pill, yes, our lungs will get the benefit of that anti-inflammatory effect, but it will also travel to other tissues in our body as well, right? Versus if we use an inhaler, then that medication only goes right to the tissue that's affected, and so that's kind of a nice thing. So we'll talk about long-term, short-term. We'll talk about all those as well. So let's just move and talk again about just glucocorticoids in general. So remember, they are anti-inflammatories. Their mechanism of action, actually there are many mechanisms of action, but the reason we want to use them for respiratory problems are they decrease the release of inflammatory mediators. And you're like, inflammatory mediators? These are things like prostaglandins are a mediator, histamine's a mediator, but in this particular case, the steroids are really blocking the production of cytokines. And then it also decreases the recruitment of eosinophils. And eosinophils usually come to the rescue when there is a perceived allergy. And again, if you don't remember much about asthma, you're going to want to go back and listen to the lecture that was done, I think by Trina Redmond, and you're also going to want to read about that a little bit more. So eosinophils tend to show up again in these areas of inflammation, and in fact, people with asthma will often have eosinophilia, meaning that on their complete blood count, you actually see elevated eosinophils. And it's really something that happens as sort of a sign of an allergy. And so it's kind of interesting thing to put together. Glucocorticoids are used for asthma. They can be used for COPD. And actually, most recently, they've been used for COVID. And we know that there is lung damage with COVID, that people end up on the ventilator. And it took us a while to try steroids, and I think we were concerned because, you know, steroids are great and they help with inflammation, but they also reduce your infection fighting capability. And if you're fighting COVID, I think there was always concern that, you know, we would harm the patient more with steroids than not. But we actually have found that steroid use in people with severe lung problems due to COVID actually respond quite well. So steroids, how do they come? Holy moly, they come in all kinds of things. They can be inhaled. They can be given IV. They can be given orally. They can be given intranasally. Anybody take a nasal spray for allergies? That is a kind of a preventative. Those are intranasal glucocorticoids. Eye drops, ear drops, and then even topicals. If you think about all of the creams that are across the counter, over the counter for swelling, inflammation, itching, a lot of those have like hydrocortisone in them. So our prototypes are beclomethasone, which is an inhaled steroid, and we'll talk about that. And then you have three other steroids that you're going to learn about: prednisone, methylprednisolone, and dexamethasone. Here's the beautiful thing about those three. If you know one, you know all three. The only difference between these three is whether they're short-acting, intermediate-acting, long-acting, and then each of these are different strengths, so we'll talk about that too. So inhaled corticosteroids, and our prototype is beclomethasone, QVAR, but beclomethasone, and it's used as a daily preventative along with other asthma meds like albuterol or montelukast, which is Singulair. Rarely do we use this inhaler by itself as a preventative. Some people I'm sure do. There's always, some group of people that don't sort of fit the norm, but often it's used in conjunction with other meds. And if you think about it, beclomethasone sort of is part of the 1-2 punch for asthma. Because in asthma, we have two major things going on. We have inflammation and we have bronchoconstriction. And so this deals with the inflammation piece of asthma. It's used to help treat an acute illness or exacerbation of asthma. So again, an inhaled steroid isn't going to, move mountains, do wonders for someone who's really, really sick, but probably as part of their treatment plan, at least, for the long haul, they'll have an inhaled steroid. It could be part of a nebulizer treatment. Again, maybe you're in the hospital with asthma, you're really sick, and you're getting an inhaled steroid and like albuterol at the same time. The beauty of inhaled medications is they have less systemic effects because the drug is being delivered to the target tissue, right? If I take a pill, not only is that, pill version of a glucocorticoid going to help my asthma, it's also going to help my, arthritis in my little finger, and it may help that inflammation on the bottom of my toe related to on my toe related to my ingrown toenail. So systemic, meaning that it goes everywhere. So if you take it orally or IV, you're going to get a distribution throughout the whole body. Versus if you take it through an inhaler, you inhale, it goes down onto the target tissue, which is your lungs, and there are fewer systemic effects. So there's less risk of things like adrenal insufficiency, the the Cushing syndrome, those kinds of things. So it's a much better option. One thing about it is because it is a steroid and it's being inhaled, it does coat the tissues of your mouth and throat. And because steroids are known to sort of turn down our immune system, we're actually at risk for getting oral fungal or yeast infections. And the one that we see the most is oral candidiasis, and that's actually a yeast. Turns the tongue kind of white, inside of the cheeks white. So you want to make sure that your patient rinses out their mouth when they're taking this medication. And then the other thing is you really want to use a spacer for better drug delivery and absorption. And we'll talk more about this in class, and there's a video in a future slide here. But this little aero chamber that you see here really helps distribute the medication and suspend it in air, and then gives the patient an opportunity to take a deep breath and inhale that. If you use a little tiny inhaler, like you see most people, pull out of their pocket and put into their mouth, I'm guilty of this. Unless you have really good technique with your inhaler, and even if you do, a lot of that drug ends up going in the back of your throat. It never goes down into the lungs. It just sticks on the tissues in the back of the throat. So spacer's really good. And it's good for all ages. It is particularly good for children and particularly good for the elderly who don't have great coordination Okay, onward. So we give these inhaled steroids. What do we expect to have happen? Well, what we expect to have happen is that there's better long-term control of the disease by having decreased inflammation. You'll note improved lung sounds and function and breathing, but over time. So just because you gave inhaled steroids at 8 a.m. doesn't mean that when you listen to their lungs at 8:30, they're going to be markedly better. In fact, they probably aren't. These drugs don't work that quickly. And so it is very important, which is why it's in the green box with the red letters, that these not be used for acute asthma attacks where the patient's having trouble breathing or shortness of breath, because they do not provide immediate relief from an asthma attack. Remember, these are not bronchodilators. These are anti-inflammatory. So you can get rid of some of the inflammation in there. You can even just begin to address a little bit, but the patient's still going to be bronchoconstricted with this drug. Okay, now we're going to move on to oral or IV glucocorticoids, and there's 3 different prototypes. And like I said, you guys already know prednisone pretty well. And then it's got its cousin, methylprednisolone, and its second cousin, dexamethasone. Okay, all of these can be given oral, and methylprednisolone and dexamethasone can be given IV. And you'll find out why, and that's because they're really potent. So these will have the same effect as the inhaler, right, as inhaled glucocorticoids, but probably a little bit faster response due to the fact that these are taken systemically. So depending on, when the onset is of these drugs and their duration of action, they're going to start to work within minutes to hours. Which is not to say that the inhaled steroids aren't, but it's, again, because you're sort of getting that like topical versus systemic effect, you're going to see the effect of these more profoundly. And I'll give you an example. So we talked about somebody with an asthma attack. If you give them inhaled steroids, they probably, like I said, are not going to be, that much better in 4, 5, 6 hours. They might be a little bit because of other things you've done, but not because of that steroid. However, if you give oral prednisone, about 6 hours after you give that dose, you will all of a sudden note, or should note, that the patient feels markedly better. Perhaps their breathing is a little bit easier. Now, that's great, but again, not very helpful for an acute, I can't breathe right this minute asthma attack. So, but again, someone who's in the hospital, who's really sick, who's in for a respiratory problem, they will be on one of these medications. Each medication has a different potency and rate of action, so I'll show you that in a minute. And they all cause the same symptoms as you previously learned about prednisone. So again, remember, they're systemic, so we're going to see more of these features. And these are the ones that I want you to know. You need to know that, this chart alone has 12 side effects of steroids. And I think that's really the take-home message here is, it affects multiple systems and should not be just taken willy-nilly. Prednisone's a great drug. It can make you feel so much better. But again, it comes with a price. And the price is things like, thin skin. You can actually have striae or stretch marks after taking the course. Usually a longer course of prednisone. Cataracts, glaucoma. We see this in transplant patients who have to be on immunosuppressive medications along with steroids for a long period of time in order to try to keep their transplanted kidney or liver or whatever. Delayed healing. This can happen with wounds. Impaired growth for kids, which is why, again, we don't just throw kids on prednisone the minute they have asthma issues. We want to use this judiciously. You guys know about increased risk of infection. It can cause hyperglycemia, and in fact, in long courses with high doses can actually cause what we call an iatrogenic diabetes, meaning we actually, cause or sort of induce diabetes, like a type 1 diabetes with these patients, and they actually need to get insulin for the period of time that they're on the medication, on the steroid. Once the steroid goes back down, then usually the patient's hyperglycemia corrects itself. And here is a really key important point here. The higher the dose of steroids, the more pronounced the symptoms, okay? So all of these things that you see on here, you will definitely see more with higher doses. And then some of these things take time. One that really comes to mind is mood changes or mania. If you give somebody very, very high dose steroids, say for a severe bowel problem, bowel inflammation, I've actually seen people kind of lose it and not remember who they are, where they are, what's going on. So, in a slightly lower dose than that, it can actually make you feel kind of revved up and like ready to rock and roll. But unfortunately, just a little bit more, and then you have mania. The expected outcomes of oral or IV steroids really depends on how fast they act. So you should get relief of inflammation, and that does help people breathe better. So you may get improved breathing, decreased shortness of breath, but it will be probably closer to hours before you really get that. Now, if you're giving it IV, you may get it a little bit quicker, but you'll have reduced swelling of airways. So again, this doesn't reverse bronchoconstriction, and I want to make that really clear. This deals with the inflammation part of asthma. And we can talk more about that when we're in class together. This oral or IV steroids actually can be used as part of a regime to treat anaphylaxis. And the one that I put on here is hydrocortisone. It is not one of your prototypes, but it happens to be probably the drug that we give the most for like an anaphylaxis because it's rapid acting. It works right away. So again, I just want to stress that systemic steroids should not be used for longer periods of time unless there's no other alternative. So when I say that, what do I mean? Well, if you need to go on steroids for 5 days because you have really bad bronchitis, you've had a terrible cold, some kind of viral illness, you can't get over it, you're still wheezing, you can't breathe, 5 days of steroids, no problem, you're going to do fine with that, your body's going to recover. If you have a flare-up of ulcerative colitis and you need to go on prednisone for 3, 4, 5 months, then you're definitely going to see those side effects. So best to use them for as least amount of time as possible. But again, use them when you need to use them. You'll just, as a nurse, you'll be the one monitoring the patient. Okay, so this is kind of a cool table. I know when I was working as a nurse, a lot of times, especially when I started in oncology, we used all of these drugs. And I was like, oh my God, they all end in "-one", right? Or "-zone", hydrocortisone, prednisone, methylprednisolone, and dexamethasone. And I was like, what is the difference? Why am I giving one over the other? How come there's so many? Well, there's a couple of things here. First of all, I made this prednisone this blue because it is the most common steroid that you're going to give. Okay, it's the one that's used the most on an outpatient basis. Prednisone is only oral, and so I thought that would be good for you to know. Hydrocortisone, I talked about in the last slide. This is, again, not one of your prototypes. So if it's a prototype for you, I have a PR here. And since this does not have a PR, it's not a prototype. It's just here for your information. It is rapid acting. And it's kind of the drug by which we judge all of the other types of steroids. So if hydrocortisone is kind of the least potent, now fastest working, but least potent, right? Then that's kind of interesting. When we go over here and look at prednisone, so prednisone is 4 times more potent than hydrocortisone. Methylprednisolone is 5 times more potent than hydrocortisone. So these two really are almost equivalent. It's just that this one tends to be given IV and this one can only be given PO. And then you get out here to our friend dexamethasone. And dexamethasone is very potent. It's 25 times more potent than hydrocortisone. Okay, so and 5 times more potent than prednisolone. So 25 times more than hydrocortisone. And I made this little arrow here for you, weaker to stronger in terms of steroids. So I think it's worth you knowing this. I think it will be very helpful to you. And you're learning these 3 prototypes anyway. So yeah, I think this is something good for you to know. Okay, onward. Leukotriene modifiers. So leukotrienes are, again, inflammatory mediators, right? They're pro-inflammatory mediators that are produced during like trauma, infection, inflammation. Now, your prototype is montelukast, better known as Singulair, and there's a lot of advertising for Singulair. It is a leukotriene modifier, and what it does is it's a leukotriene receptor blocker. So when it blocks that leukotriene receptor, it reduces bronchoconstriction and inflammation caused by leukotrienes. So it's kind of a 2-for-1. It's a great drug, and it's often used for long-term treatment of asthma in children and adults. So I take this medication. I have asthma. I've had it my whole life, and I take it at night. And it really helps my nighttime symptoms. In fact, if I don't take it at night, I notice a difference. So it's great. And by taking it, it really reduces the use of beta-2 agonist medications like albuterol. So I have an albuterol inhaler. I have one everywhere. I have one in my backpack, in my purse, at my bedside, downstairs, upstairs, in the kitchen, in the car. And I have them there because I do have asthma. And if I get wheezy, I don't want to not have it. But I notice that when I consistently take my Singulair, I use far less of that inhaler, that rescue inhaler. So it's an excellent drug. The thing you need to know about this is not effective for treating an acute asthma attack. So if I wake up in the middle of the night and I'm feeling really wheezy, I am not going to go pop a Singulair tablet. That is not going to help me. I will actually need to use my albuterol inhaler, which is the only medication that you can use as a rescue medication for acute bronchoconstriction. The rest of these just don't work fast enough. They're great drugs, but they don't do anything quick enough. Okay, there is a black box warning on Singulair. This is really interesting. Actually, I did not know this. I should probably tell my husband this. But it can cause neuropsychiatric events. Agitation, aggressive behavior, anxiousness, depression, disorientation, suicidal ideation, and dream abnormalities. Now, of all of those, the only thing I have at all that I could even begin to attribute to this might be dream abnormalities. I do have very bizarre dreams, but I've been having them for a really long time, probably before I started taking Singulair. So the expected outcomes of taking leukotriene modifiers is that the patient should have improved asthma symptoms kind of all around, which is what I noticed by taking this. Relief of allergic rhinitis or absence of exercise-induced symptoms. And I would say that I have all three of those as a result of taking Singulair. So it is a great drug. I see we have depression here. That must be a combination between depression and congestion. Okay, so we have just finished. Those first 10 slides are all about glucocorticoids, all right? Actually, sorry, the first 8. So there were 8 slides about glucocorticoids. Then the last 2 were about leukotriene modifiers, which is oral Singulair. And now we're going to move to MAST-CELL stabilizers. It's kind of funny that they have you learn this as a prototype, but I do think it's important. Cromolyn sodium, or cromolyn, also known as nasal crom, is the MAST-CELL stabilizer prototype. You can actually purchase cromolyn over the counter. So here's the thing about cromolyn is it's an okay drug, but check this out. Not super effective. Okay, so it's not really the drug of choice. It's great for, so your mast cells are these cells that line a lot of your tissues. You actually have tons of them in your nose. And let's just say you bend over and smell this flower and you are allergic. The pollen or whatever's in this beautiful flower makes you sneeze. If you were to take a mast cell stabilizer before you went to sniff the flower, you might make it such that those mast cells aren't quite as quick to release their histamine when you smell that flower. So I don't know if that makes sense, but it's kind of like, I don't know how to say this, but I mean, it basically sort of tells those mast cells like, hey, when you sniff the flower and that allergen is right there, you're not going to release your histamine, even though you want to, you're not going to do it. So that's it. It's a mast cell stabilizer. It is not preferred over inhaled steroids. And again, like I said, not super effective. It can be an alternative prophylactic medication for asthma. It might be used kind of as a last-ditch effort, actually. If other drugs haven't worked very well, they may try a mast cell stabilizer. And again, it's usually used with other asthma meds. So it's not something that, most people take alone. This is not effective for treating acute asthma attacks. It has nothing to do with bronchodilation or really inflammation in the lungs. So really the only thing this is good for would be like, again, preventing the release of histamine from cells when confronted with an allergen, which might be the cause of some of the inflammation and some of the problem. But once the problem's happened and you have inflammation, this drug is not going to help you. But not only is it not super effective, there's almost no side or adverse effects, and that's because it doesn't really do much. Okay, but it's a good one to know, and it is something that you can get over the counter, and we would want you to know it because patients may tell you that they're taking it. Okay, we're going to move on to adrenergics. Now we're going to get into some of the inhalers that you do probably know or have seen working in the hospital. So remember, adrenergics, these have, they're sympathomimetics. They mimic the sympathetic nervous system, right? Remember, sympathetic nervous system is fight or flight. I always use the analogy of running from the scary monster. And if you are running from a scary monster, what kinds of reactions or things is your body going to do, right? So that's a really good way to sort of think about it and know that these drugs sort of mimic our sympathetic nervous system. And we're going to start with inhaled drugs here. So our prototype here is albuterol. The brand name is Proventil. There's another one called Ventolin. Anyway, it's an inhaler. Albuterol really only comes in an inhaled form. You can have an inhaler, and then you can actually have albuterol that like the respiratory therapist will use and put in a nebulizer. Actually, a lot of families have nebulizers at home. We had one at home when my kids were little because they have asthma too. That's a gift that I gave them. And so when they got sick, we were able to do our own nebulizer at home, and it basically kept us out of the hospital. My children were never admitted for an asthma-related event, even though they spent many days at home sick with asthma. So albuterol is a short-acting beta-2 adrenergic agonist. And I don't know if you learned this when you were learning beta agonists or beta antagonists, like beta blockers before, but this is really helpful. Beta 2 is in the lungs. That's where beta 2 receptors are. And you can remember that by 1 heart, 2 lungs. So beta 1 receptors are in the heart and beta 2s are in the lungs. Okay? And this is a potent bronchodilator. So think about it. This is an adrenergic, right? We are running from the scary monster. What is our body going to do to try to help us get away? Because this is fight or flight. This is, are we going to live or are we going to die? And one of the things it will do is it will actually bronchodilate our lungs so that we can get more oxygen, so that we can keep running and we can keep fighting, right? So it is beta 2 agonist bronchodilator. It stimulates those beta 2 receptors in the smooth muscle of bronchi and bronchioles, which produces bronchodilation, which means that those tubes open up. They get bigger, which allows more air to go through. So this drug can be used as a rescue inhaler for shortness of breath, dyspnea due to asthma, COPD. Sorry, I don't know what it means, but this is the only rescue in the moment, need to open up those airways inhaler. All the other inhalers that we talk about in this slideshow, they don't work that way. They'll work eventually, but they don't work this way. So the side effects, because it mimics sympathetic stimulation, right, then it's going to cause sympathetic side effects like jitteriness, tachycardia, tremor, shakiness. It's not unusual for somebody to get done taking a puff of their albuterol and feel shaky or kind of tremorous. Okay, and if you've had it in a nebulizer, you'll really feel that way. It can cause agitation, anxiety. So those are the side effects. They're mostly that that kind of overkill sympathetic piece. And then we want to do cautious use in people who have hypertension, because this can make it worse. Seizure disorders and diabetes. And you're like, diabetes, what the heck? Well, it's not that albuterol has anything to do with glucose levels. It really is the fact that you have that sympathetic stimulation. And that may cause you to make a false judgment about whether you're hyper or hypoglycemic. So we just want to be really careful in using this in that population. It's 1 to 2 puffs usually, and usually it's 5 minutes between each puff, right? So usually it's 2 puffs. So you'll take a puff, wait 5 minutes, kind of let that first puff do its thing, kind of open up the airways a little bit, and then you'll do the second puff, which hopefully will go in and get you to where you need to be. Okay, so here's my beta 1, beta 2, 1 heart, 2 lungs, and albuterol sulfate. And this is what it comes in, is this short little MDI, which is metered dose inhaler, meaning that it gives out the same amount every time you push down on the little can, and it sprays out a dose. Okay, so here you go, multi-dose, metered dose inhaler, and watch this video. It's from the CDC. It's 1 minute. It's excellent. This med is best used with a spacer. Actually, almost any inhaled medication, especially for asthma or COPD, any kind of lung issue, really delivered better through a spacer. A spacer is this plastic tube. You can hook you'll see it on the video, but you can hook your inhaler in. And what it does is it allows the medication, again, to be sort of distributed through the air and not just sprayed on your teeth or the back of your throat. So it really gives the patient the best dose of medicine. It gives them the most medicine, and again, nicely distributed. So what expected outcomes should you have when a patient is taking this med? Well, right away, you should see decreased work of breathing and decreased tachypnea. This should dramatically improve their ability to breathe. You'll have decreased wheezing and coughing, although sometimes patients are so tight when they take this medication that when they do take it and it opens up their bronchial tubes, that's when you'll hear people coughing, and they'll cough up a bunch of stuff, and then they feel a whole lot better. But ultimately, if you are evaluating someone 15 minutes after doing 2 puffs, they should be feeling markedly better. They might feel jittery or shaky, and like I said, they may cough initially as airways open and mucus is expectorated, which just means coughed up. And the problem with this is it's so darn convenient that people tend to use it as their main form of control for asthma, and it really is not good. It really should not be used to control asthma long term. Our bodies can get used to this and kind of be like, okay, a little albuterol, not going to really do that much for me. And so it takes more and more and more of the medicine. And when you notice that happening with a patient, if they tell you like, oh yeah, I was taking like 2 puffs a couple days ago, and now I'm taking like 10 puffs a day, you need to know that they need intervention. They probably are going to need a steroid or something else to help them get their asthma under control. Okay, salmeterol. This is also a beta-2 adrenergic agonist, but there is a huge difference between this and albuterol, and that is this is a long-acting maintenance drug, which means if you take it for an acute asthma attack, it is not going to help. So if I, go out and I go for a walk or a run or hike and I start getting wheezy, I can't pull this out of my pocket and use this. It is not going to help me in that kind of rapid, I need it right now way. This works for more long-term control. And actually, if you take this, again, you'll have to use less of your albuterol because this should control bronchodilation and really help with that over the long term, meaning over 12 hours or so. It's usually taken as part of a daily regimen. And I put up here Advair. Advair is a really common drug that a lot of people with asthma take. And it's a combination of fluticasone and salmeterol. And there's different concentrations of it. So 250-50 has to do with how much steroid versus how much beta-2 agonist. Same side effects, expected outcomes as albuterol. And remember, because this has a steroid in it, you're going to want your patient to rinse out their mouth when they're done with this. Black box warning, use in patients with worsening or acutely deteriorating asthma may be life-threatening. So again, do not rely on this drug to be your savior if your patient's really wheezy and having a hard time breathing. This is not going to work. Okay. Anticholinergics. So it's kind of funny. I don't know why we call things anticholinergics, but I think it has to do with the receptors that it works on. So it works on the cholinergic receptors, but the effect is the same as a sympathomimetic, right? Or a sympathetic system drug. So cholinergic is the rest and digest part. Remember, adrenergic is fight or flight. But anticholinergic means anti-rest and digest. So essentially, it's the same as an adrenergic. I know that's confusing. We can talk about that more if you want to. Okay. The drug here is called ipratropium or Atrovent. And it's called Atrovent because ipratropium actually works a lot like atropine. It's used to treat bronchoconstriction due to asthma, chronic bronchitis, or emphysema. And it blocks the muscarinic acetylcholine receptors in smooth muscles of bronchi. So it inhibits bronchoconstriction and mucus secretion, which is kind of cool. Sorry, I don't know, I have that little ipratropium in there. But it improves pulmonary function within a few minutes. Now, improving pulmonary function within a few minutes is very different than saying it can be used for an acute asthma attack. It may improve pulmonary function. This drug is actually used a lot for people with COPD. We don't really use it for asthmatics. You know, as an outpatient treatment, it can be used in the hospital if somebody's really having a bad time with asthma. But not good for acute asthma attacks. So again, I know that sounds really strange, but it can be used with other adrenergic bronchodilators. So you could actually put like ipratropium and albuterol together in a nebulizer and give that. This just hits a different receptor, right, to cause that anticholinergic effect. The expected outcomes of this, again, reduced rate and improved quality of respirations and pulmonary function, and the patient should report that breathing is improved and anxiety is reduced. So it's a great drug, but it's, again, not really designed for that acute asthma attack. If you are going to use it for an acute asthma attack, it has to be used with another, with an adrenergic as well. Okay, anti-tuberculars. There's only a few of these and then we're done. So tuberculosis, whoops, it's one of the top 10 causes of death in the world. And we now have what's called multi-drug resistant tuberculosis. Tuberculosis is considered multi-drug resistant if it's resistant to at least isoniazid and rifampin, and requires more than one drug to treat. Again, we're not going to get into all the various treatment regimens with tuberculosis because it's complicated. But I do want you to know that there is this multi-drug resistant bug. And inadequate treatment of multi-drug resistant will lead to further transmission of the disease to others and death for the patient. You know, this really came about, there'd be big problems with this where maybe like USAID or other aid organizations went into various countries, one of them being Haiti, and said, oh my gosh, there's a tuberculosis epidemic here, well, let's treat it. Well, what we did is we threw a single drug at it, and quickly these patients became multi-drug resistant. And the U.S. government just sort of said, well, you know, something's better than nothing. And there were a few physicians who worked in that area who said, no, actually, it's not better than nothing. It's actually causing this multi-drug resistant TB to perpetuate. And so now the drugs that are used to treat TB for the most part are fairly inexpensive. And so we have different regimens now to try to battle this multi-drug resistant tuberculosis. We also know that in some places of the world, there's extensively drug-resistant TB that is resistant basically to all the drugs we have available, plus fluoroquinolones and other what we would call second-line drugs, kind of things we would try if first-line drugs don't work. But there's effectively no treatment for this type of TB, and it becomes a death sentence. So it's not something that we want to see perpetuated out in the community. transmitted. So drug therapy for TB, people get drug therapy if they have latent TB. This is like a positive TB test that, they think that you have TB and you're going to need to take TB drugs for 6 months, versus active TB, where we know that there's active disease in the lungs. Patients have symptoms, sweats, fever, weight loss. So we're going to talk about both of those. Use of multiple drugs is needed to prevent the development of drug-resistant TB. Now, not so much with latent TB, but definitely with active TB. We need to use multiple drugs. Determining drug susceptibility is really key to effective treatment. We do that by taking a sputum sample and doing cultures and sensitivities on those. And then treatment can last anywhere from 9 months to 2 years. So depending on whether you're latent, whether you're active, just depends. And then we do use something called direct observational therapy. It's used in the U.S. for high-risk patients or those who are on really complex regimens. And a lot of research has been done to show that direct observational therapy is more effective in terms of compliance and patient outcomes in the long run. But it's expensive because basically somebody has to come to your house every day and give you meds. But they do this for people who are homeless. It's very, very complicated. But active cases of TB in the United States, even in Spokane, I don't know what it is right now. It'd be interesting to look that up and see, but I'm guessing that it's no more than just a few cases of active TB, if any at all. I know in San Diego, which is a big city, 4 million people, they'd have maybe 30 or 40 cases of active TB at any one time that they're aware of. Okay, our first prototype here is isoniazid, INH. This drug has been around for eons. Its mechanism of action is that it inhibits cell wall synthesis. It is the most commonly used anti-TB drug. It's bactericidal and inexpensive and relatively non-toxic. So really popular drug. And I've actually had a number of students be on INH for latent TB that's been discovered. Okay. Adverse effects, you're going to notice a theme as we go through these 3 drugs, and the theme is hepatotoxicity. Okay. This drug also happens to have peripheral neuropathy in high-risk patients. Again, high-risk patients would be people who are at risk for hepatotoxicity. One of the things we'll do is in high-risk patients that we think may get peripheral neuropathy, we will give them vitamin B6 along with the drug, and that seems to help prevent that effect. Contraindications, again, you're going to see a theme here as we go through these 3 drugs, but people with liver disease, caution in chronic alcoholism, the elderly, absolutely no alcohol while taking the drug. So this is a big deal. This is probably the big side effect contraindication for these drugs. And your nursing care is to observe for signs and symptoms of active TB, especially if they're just taking it as a single drug, because if they're taking it as a single drug, they just have latent TB, and you always want to make sure that latent isn't turning into active. You would also want to watch for increased liver enzymes, bilirubin, and then because of the fact that it causes peripheral neuropathy, you would want to look for those signs and symptoms like numbness, tingling, even pain. The second drug we're going to learn is rifampin, and that has been abbreviated as RIF, R-A-F, and it inhibits RNA synthesis. Can be used alone for latent TB infections or used for INH resistant TB. So if we have someone on INH and they're they've been on treatment for a while and they've been tested and their sputum still come back positive, then we would switch them over to this drug. This drug can also be used as prophylaxis for exposure to meningococcal meningitis. And that's actually an interesting thing to know. If you have, you guys are college students, and if you have a friend or someone who comes down with this, it's important to know that if you've had exposure to the patient, that you will need to go on prophylaxis so that you do not develop meningococcal meningitis. Adverse effects, again, GI upset, hepatotoxicity. This can also have renal failure and skin rashes. Prolonged use can lead to C. diff-associated diarrhea. So this drug can really wipe out your gut bacteria. Here's the other big thing about this one is there are many drug reactions with other drugs. Many, many, many. So this drug does not play nice with other drugs. And you really need to watch look carefully at what other drugs patients are on. Things like warfarin, which is used, to prevent clots. This drug can actually increase the risk of bleeding. So you want to be really careful about that. And then use cautiously in people with liver disease and those with a history of alcoholism. Even if they're not drinking now, this drug can be really hard on their liver. So same observations and precautions as INH. Monitor liver function, report signs and symptoms of liver toxicity ASAP. And we just talked about all those GI signs of liver problems. So the elevated labs, elevated bilirubin, jaundice, pain, those kinds of things. And then the last drug here is pyrazinamide, PZA. And this is also bactericidal, but we don't really know exactly how it achieves its bactericidal properties. It's used as part of multi-drug regimen along with INH and rifampin and ethambutol for active TB care. So you'd see this one less for latent TB and more for active TB. And again, hepatotoxicity. Surprise. This one's kind of highlighted side effect is that it can inhibit uric acid excretion, and that can lead to uric acid crystal formation, which can cause gout, which is painful crystals, these uric acid crystals in the joints. And so that's something you would want to watch for. If all of a sudden your patient's telling you that they have horrible arthritis or their feet hurt, that's a lot of times where you'll see a lot of gout symptoms is in the toes and in the feet. You may have someone who's developed gout. And then patients with pre-existing liver impairment should not take this drug unless it's absolutely essential. So there would need to be lots of monitoring for that. All right, you guys, we are done. These are your meds for respiratory.